Hi everybody, and thank you for joining me in this short video presentation regarding the ECG exercise number 6. I hope you will enjoy this video and join me in my future video presentations. The ECG belongs to a 34-year-old man presenting with dizziness and tachycardia. He underwent successful cardioversion, and we will see in the following slides his ECG before and after cardioversion. Here we see the clinical tachycardia, a wide complex tachycardia with left bundle branch block pattern and late RS transition. There are several algorithms available to differentiate between ventricular tachycardia from supraventricular tachycardia with aberrancy or pre-excitation, and in this video we use an algorithm based on lead AVR from John Miller's group. The first step is to check whether AVR is positive or not. The second step is to check if there is an initial Q wave or R wave lasting longer than 40 milliseconds. This is also not the case in our ECG, and therefore we go to the third step, and the third step is to check if there is a notch on the downstroke of the negative AVR deflection. The last step is to check if the initial vertical excursion in millivolt recorded on the ECG during the initial and terminal 40 milliseconds of the QRS complex is equal or less than 1. It means that activation of the initial part of the myocardium is not due to a specialized fast conducting cardiac conduction system, and even this is not the case in our ECG. So based on the described algorithm, the most likely diagnosis would be a supraventricular tachycardia in this patient. The next clue to the potential diagnosis is in the resting ECG. There is no sign of PR shortening. Even the septal Q wave in V6 is visible. The only hint for a potential diagnosis is the Q wave in lead 3, and this pattern in conjunction with a wide complex tachycardia with left bundle branch block pattern and late RS transition could be a clue to the diagnosis of atriovascular or nodovascular bypass tract, or so-called Mahan fibers. The patient underwent EP study where the diagnosis was confirmed. This is his resting ECG after ablation. The initial Q wave in lead 3, representing the initial activation via the atriovascular bypass tract, is eliminated after RF ablation. In summary, we have to always think of Mahan accessory pathway in patients with wide complex tachycardia with left bundle branch block pattern with a left superior axis, a late RS transition, and a structural normal heart. Patrick and I would like to thank you for your attention, and we hope to have you here in our future video presentations. Thank you.